This is going over chapter 49 in your fundamentals, excuse me, fundamentals text on sensory alteration. Some few words, some terminology. You've got sight or visual, obviously that's kind of self-explanatory. Hearing, auditory, touch or tactile. Smell or olfactory. Taste, gustatory. Position and motion is kinesthetic. Size, shape, and texture is stereognosis. That's basically a sense where you can have somebody close their eyes, put something in their hand, and say, "Okay, tell me what it is." That's part of a neuro. Normal sensation you have. Basically, it's three different parts of this. Is the receptor, which is recepting. It's the feeling. You have perception, and you have your reaction. You have different things. You can have, with sensory alterations, you have sensory deficits. Deficits are what we usually talk about if someone has lost something, like a lot of times with a stroke patient, they have left-sided deficits, meaning like if they have left-sided weakness. But any kind of deficit is a change or a decline. So with the different deficits, it could be a visual or hearing loss as someone gets older. It could be balance from like dizziness. Maybe they have a problem with their ears. They've got vertigo. Taste or smell deficits. We saw that a lot with COVID, right? It's called xerostomia. That's a decrease in salivary production leads to thicker mucus and a dry mouth is xerostomia. You'll see that word again. It starts with an X. And of course, we got neurological deficits. That's what I was talking about, like with the stroke patient. So those are deficits. You also have sensory deprivation. This is something you hear about a lot of times when people, like in prison, they're in solitary confinement, when they're not having their senses used or being stimulated. Now they start having sensory deprivation. They start having reduced sensing of of either sight, hearing. Also, oh, that can also be from drugs, like psychotropic drugs can also cause some sensory deprivation. And then, of course, we have sensory overload. Now we see this a lot with like even like autistic children. They don't like too much stimulation or too much overload. When you have too much coming at you, just any of us, it tends to overwhelm us and stress us out, doesn't it? It's a sensory overload. Different things that can influence your senses. Age, obviously, that's the big one. Um, we typically think of as people get older, they start losing their vision, or like maybe cataracts. They start having deficits, being able to see close up. I'm an example of that. Hearing deficits. Um, Meaningful stimuli. Meaningful stimuli. That basically means that when someone is like in a hospital, if they, especially older people, you see this with a lot of older people, they have a delirium. It's a hospital acquired delirium. Once they go home, it resolves. So you need to remember that when you are caring for someone in the hospital. My father went through that when he was in the hospital. Just sensory, just too much of the lights being on, 24 hours a day, where they come in, and turn on lights in the middle of the night, or having, the alarms and beeping. It caused him to kind of have go into a delirium because of it. Talks about amount of stimuli. Again, excessive stimuli, but also not enough stimulation that's deprivation. Social interaction, environmental factors, cultural factors, they're all part of this. You can put that on your own critical thinking section. Through the nursing process, first thing is assessment. Assessment, always look at things through the patient's eyes. Always think about what uh, the patient is going through. Think about, um, gather information from them. And now remember, sometimes people don't, especially when you get older, they don't like admitting that they can't hear as well or they can't see as well. So, just assess them and try to put yourself in their place, be a partner with them. People at risk, you need to think about people that have hearing losses. We'll talk more so probably in the lab about how to talk to someone with hearing deficits because it's not just the loudness or softness, often it's tone. So usually when people get older, they can't hear higher tones. So if you talk in a really high voice, "Hi, Mr. Smith, how are you today?" He can't hear you, so you have to lower your voice. "Hi, Mr. Smith, how are you today?" You speak lower and slower. My dad used to get so mad because you'd have these, young females at the hospital come in and they're speaking in a real high voice and he couldn't understand them. So he'd be like, "What?" So then they'd be like, "Hey, how are you?" And they'd like yell, really loud, but still in the high pitched tone. And he'd get mad. He was like, "Why are these people yelling at me?" So we'll talk about this more, especially in lab. We will talk about how to talk to someone with hearing loss. We always want to look at someone's history of what kind of any eye, sight, hearing, touch. Um, of course, their mental status, we take into consideration that. We do our physical assessment. We determine whether they are able to perform self-care. Or are they able to, like, maybe someone that's had a stroke or something, are they able to dress themselves? Um, so we have to consider things like that. And of course, environmental standards. We always want to look at the environment. We want to look at um, safety. We want to look at someone that's maybe having some visual disturbances. Maybe they're having some cataracts and they don't see as well. You have to consider things like, are there um, throw rugs where they could slip on them or cords that they could trip over. So you always have to consider environment. Um, Again, communication methods, social support, use of assistive devices. There's a lot of assistive devices to help people with deficits. We will talk more about those in lab. I mean, obviously, different things with like even helping people get dressed, putting on their socks. There's these nice little things that have it's like a long pole with a little um, clasp at the bottoms where they can pull their socks on. There's different things that we help people cope and be able to care for themselves. For nursing diagnosis, you would look at things like risk for injury, risk for fall, impaired communication, impaired socialization, impaired mobility. Those are just a few of the nursing diagnoses that could go along with this. Of course, I'm sure there's many, many, many more. And then planning, you want to look at their outcomes. You want to set priorities. Um, okay, obviously, if someone has a permanent deficit, your outcome is not going to be, oh, they're going to be able to see. I mean, you always want to get someone to the best that they can be, considering um, the deficits that they have. Implementation, that's where we would, maybe use the assistive devices or any kind of meaningful stimulation depending upon their any adaptations or for visual or communication or adapting the environment. All right. And then the evaluation, last step of the nursing process. You